And David, I will go ahead and turn it over to you to begin today's session.
Great. Thank you very much, Allie. Appreciate the introduction and the pre-work. And thanks and welcome to everyone that's taken the time to join today. My name's Dave Winn. I am with RHIA Health, which is a for-profit entity recently created under the Parkview Health umbrella. And the mission for RHIA Health is pretty simple. Before I move into what Parkview Health's about as a background, we were created so that we can actually take products and services out to market that help independent hospitals stay independent. And as I like to say, not just survive, but thrive. And I've been wanting to do this for years. My background with Parkview was to help create a EMR sharing program, which we've been running for 14 plus years into the 15th year now. And it's worked really well, and there's been a tremendous amount of value. But one of the things that I felt was there was always more things. Having the technology and the software in place was great, but we've gotten into such complicated areas now, especially with the funding, and we'll touch a little bit on it to kind of set the stage in the next couple of slides. But you all know it's tough and getting tougher, and you just kind of wonder, what can I do? Where can I go? And that's something that I've been really appreciative and excited about, is that now I have some more tools in the bag that I can work with. But before we go too much further, just a little bit about Parkview Health. It says 14 hospitals on it, but if you read a press release, it looks like there might be another one joining here pretty soon. But it kind of goes to the state of the market, right? Always have to do a little housekeeping. No conflict of interest, at least that I'm aware of. I like to share that the research that I've pulled together for my purposes, which I'm sharing with you and the group today, is targeted on just a few areas, but there is analysis and work that I'm getting from all sources, right? Published articles, hospital and vendor shared resources, and of course, using AI tools for research and analysis, which really does help, I tell you. Big difference in some of this time savings and benefits. Also like to point out that in where we are with this, and I know you appreciate it, but I have to say it, we all have different perspectives and different opinions on what's going on and what we're doing. So I'd like to share that these are my opinions, and they don't necessarily represent the views of my employer or any of the affiliated organizations that I work with. All right, so topic was leveraging technology, specialty services, and supplier support to remain independent. And again, it's not just to be independent, right? I'd like to see my customers not just surviving, but finding ways to thrive. So in the structure here, we just had 3 learning objectives. I don't know if there's CEUs, but I set it up just in case you have CEUs for any other organization and you can be compliant. But we'll start off with just a quick level set with where we are with the headwinds. A few key targeted areas that show strong potential for gaining the Rural Health Transformation Program funding. How can we help boost revenues, retention of earnings, and creating community value and benefit at the same time? Nothing here is going to be a sales pitch, guys. Just want to make sure we notice that. These are products and services you can get from a number of places. Just happens to be the targets that I feel probably have some of the biggest and nearest impact that we can get to. And it lines up with where we are with headwinds and what we might be able to do with rural health transformation. And secondly, understanding how collaboration among health systems and suppliers and regulators can reduce the cost and strengthen rural healthcare sustainability. In my experience in 14 years of working just here in this market with Parkview Health, I found that we just can't do it alone. I think that we need to have a combination of resources. It's not necessarily just hospital, but we need vendors to start playing ball with this. We need to find different ways. And I know we've had lots of organizations like SHO and others that folks are trying to form groups to try to get better buying power. And I think that's meaningful and it's right. But I'm not sure we've always hit the mark. But I still think the old is forever new, as Dale Carnegie once said. We need to try to just keep poking at it until we can find a solution that works. So the agenda, we'll just go through the current state real quick. The 4 topics that I'm going to cover would be EMR sharing and hosted solutions. There's a number of brands out there, but we're just going to talk about what the value of that would be. Virtual care, revenue cycle services, pharmacy management. I'm thinking 340B and some other things that are going on that folks really want to hit well, and that seems to be a moving target. And then we'll just wrap up, as Ali mentioned, with a few final thoughts and some Q&A. So I won't spend a lot of time on the headwinds, because if you're reading the same things I'm reading, this week alone, we're getting bombed with all sorts of just wonderful news, and I'm being very tongue in cheek. But when you start looking at what Indiana's dealing with, over the next 10 years, we're talking about 1.1 billion in losses. We've got some numbers out there about the number of Indiana hospitals that are operating at a loss. The reimbursement rates for Medicaid dollars dropping, and we still haven't even gotten to 2027 yet. So a lot to think about there. We want to look at risk service reductions and hospital closures. You look at a hospital system like mine and you think, yeah, that's probably not a big deal. But it technically is. Whenever you lose a hospital, it's painful for everyone in the community. Patients have to now travel, but where are they going to go? They're going to go to another hospital system that might be another county hospital, another rural health location, but it also may end up at some place like like Parkview Health. And when you start looking at capacity and resources, that creates additional strain that obviously isn't helping us as much as everyone might think, but it also has just more downriver pain. And I think the idea needs to be, how do we keep rural hospitals doing their thing, working independently and providing the services? I think that's critical and something that's on my mind every day. So we start looking at 25% of cuts that are already happening. I read an article this morning about OBGYN, and it's a desert in many places. I mean, we used to talk about food deserts, but now we're talking about actual services, and OBGYN's a biggie. People want to have their babies right where they were born themselves. They don't want to have to drive 45 minutes to an hour to go get that done. It's just painful. And then, of course, behavioral health, surgical lines, and ERs. All these are all woven together and all super important. Workforce shortages across the clinical and operational areas. We're having those impacts. Nothing's getting cheaper. Everything seems to be going up around us. Doesn't matter where you look. But again, with reimbursement going down, we're really heading into a long stretch. And then there's technology and modernization gaps. These are things that have to be addressed, especially too, if we're going to do something with rural health transformation. Just another couple slides here I thought were interesting. A lot of you may already know this. There's the dollars. I have Ohio too. I spent a lot of time in Ohio, so you can kind of see how they're comparing to Indiana, but no one can like the numbers of the risk here on the top right, and those just aren't good. And anything we can do before it's too late is something I think that we should be talking about today. And wherever you can find resources to make these things better, I hope it helps, and then we can make it work. Rural health funding, yeah, we know the numbers, 206.9 for Indiana. Ohio was pretty close. I feel bad for Michigan because they got less than 170. So it's just all over the place, and they need as much help as we all do today. We talked about the targets, so I won't run through this screen again, but these are the things that I'm trying to address today with what I think is important, and I wanted to share with you, and some things that I put a little bit of research in. A quick pause there, Allie, if there was anything you wanted to hit me up with.
Just had one person double checking whether we were recording today, and we are recording. We will have this posted to our YouTube channel in about a week and a half.
Super. Thank you. I appreciate that. EMR hosted and sharing solutions. So I have one that I work with. I won't mention the names, trying to be respectful for everyone, but there are other systems that do this. But if I happen to mention one that begins with an E, I apologize. It might be just habit. But there is a need for EHR sharing programs. I think that we're dealing with rural populations that have those lower incomes, lower levels of education, limited access to healthcare, and limited health insurance access. Everybody's got to have these hospitals in existence, but when costs keep going up and it's super expensive to do this, I read an article that the average rural health hospital, let's think critical access and a little bit larger, $8 to $10 million seems to be the number that we see a lot. And some of the vendors won't do it directly with you. They would want you to form into some of these groups, and they're out there. So the other 2 or 3 major players that I see from a hospital and clinic environment do have a lot of sharing opportunities. So I think there is definitely a market for that, and making sure that it's affordable to keep the patients in the communities that they're in. So the benefits of doing these EHR sharings, there's downsides too, right? So feel free to throw a question out there. I'll do my best to answer it if you see any, but there are some. But overall, though, I think it's overwhelmingly beneficial. There is one unified platform. Approved patient care, because you are sharing a lot of work, that knowledge that's going in from every hospital, every provider that's pouring in their content, their thought, their knowledge into the build and what's happening with that EMR that you're sharing with. So there's huge savings there. And of course, we keep going back to getting all of that, but making it affordable. I'm hearing things coming out of the state of Indiana, but of course, all across the country, it's the same thing. The legislatures are trying to drive how do we do something that's like putting an HIE on steroids? Well, if everybody used the same EMR, we've heard that for years. Why don't we just do what Canada does or England and have one EMR? I'm not sure if that's entirely realistic, but in our environment, it can make sense. So if the state was going to drive that, we don't know how they're going to choose, how they're going to lean into. But if everyone technically was on the same EMR and sharing the same instance, if you will, where a patient travels between any location and you know where they came from, but that medical record, not the billing, not the financial, not scheduling, nothing that's business that has to stay private, but anything on that patient's clinical record was available as though everything happened in your place. That's the key. You don't have to go hunt for it. You don't have to pull another resource and click and download and pick and choose what you want. Everything needs to be there at your fingertips so that continuity of care extends not just within your hospital or the one next door, but across the entire state. And I think that's kind of what we're seeing in some of the things I'm reading from the rural health transformation of what's being driven and what we're being asked to do. A few benefits of the EMR sharing. I won't try to read all the slides, but you get into compliance is a factor. State and federal regulations. I've had this slide I've probably been working this slide for a couple of years, to tell you the truth, and there's always been compliance. But now that we're starting to see some very direct things on how much money we might get from rural health transformation and how things might be allocated, that's becoming even more important. So we have to try to make sure that we're putting all of you in a position to benefit, to have outstanding data for your grant applications, and that we have very strong reporting to meet everything that's going to be coming down the pike, because this is a 5-year program, right? So we've got to make sure that we can get into the game, get the most you can, how to be able to make all the benefits, save where you can, do better with what you're already doing, and make sure that the funds are keep rolling in. And that's going to be largely on what's the reporting, what's the outcomes. And we don't have all those defined yet, I'm sure of that. But again, we want to look at improving the operational benefits. So that's getting into financial data analytics and trending it, but we need to do it in an affordable way. And continuity care all the way through this whole theme is taking care of patients where they need to be taken care of and in the best possible way. On data conversion and archiving, I put that in because there are a lot of conversions, right? If we do something like this, you're going to move from one system to another. So this is a great opportunity, and I'm a giant fan of consolidation. And there's a lot of reasons for that, but if we think about it, having all the data in one place just seems to make sense. But we need to be able to do these in a fashion to where we're bringing the data over, we're normalizing the data definitions between all these systems mean the same thing, because when you drop them into these larger resource pools, these data lakes, if you will, that has to be extracted out. Maybe you're running AI against it. Maybe you're running some predictive analytics against it. We're certainly going to be running a lot of reporting that's going to have to go through not just the state, but up and through the federal government. This all still has to make sense, and it has to be meaningful. So these conversions become super important. We need to make sure that we're picking the right vendors when we do this. Data archiving can come from a number of places. I see them all the time in my travels. But we need to make sure that as we're the buyers, and I'm talking about all you out there in rural health, as you buy these products, make sure you're finding folks that are good partners, that understand what you need to do, that can consolidate and bring in all these other legacy systems and bring that consolidated down into one source so that from there you can start applying all of the right tools that you're going to need going down the road. But we talk about continuity of care documents come over. That's pretty easy. Patient transporter is an epic term for making sure that we're bringing all the PAMI and so forth over. But abstractors are going to be needed in certain cases because no one knows the data that you have better than your own team. So don't think that AI and software is going to be the magic wand to take care of all of it. It's still going to take a big lift, if you will, but doable. One of the things I caution everyone on, and again, this is 29 years before I got to Parkview, by the way, working with vendors doing EMRs and other products. Terrible idea to try to convert the financial. And also, I would suggest the scheduling. It doesn't work well. You end up with more work and confusion at the very end. And again, when you start dealing with data that's going to land somewhere into some sort of a database that you're going to be counting on, if it's wrong, then that's going to spin off a whole bunch of wrong data and wrong results and outcomes. So not a big fan of converting the financial data. There's solutions out there to do that, but obviously if you can run it off your existing legacy platform, that'd be the way to go. New revenue results out here. Again, I like that everybody knows that we can talk about the story, but some folks, really need to see the results. I'm a data guy. So when you start looking at where you have improvements, you start seeing some pretty decent numbers. You want to be in the 90s in claims management. And when we start looking about average AR days, I used Parkview's number. It might be even a little bit better now than this. The slide is a couple years old. But what we find is when we add some of these folks into the sharing, they're benefiting for all the work and the tools that are already put into the system. We almost instantly start seeing improvements. And I think that's the same thing that holds true from any of the major suppliers that you might be working with, because everyone's leveraging everyone's knowledge. So we're working more collaboratively than we thought. And I think that's a huge benefit. So some of the benefits to the rural health hospitals on this particular area, again, CMS requirements for FHIR-based API interoperability, that's definitely published. Not all systems that are out there can meet that today. Shared infrastructure reduces IT capital expenditures. We talked about the 8 to 10 million, but we didn't talk about the annuals, right? All this stuff is impacted. You also have to think about if you have your software hosted someplace else, that might mean that you can reduce some of the staff, or at least have the staff you have burdening themselves with other areas that were more important. So big piece right there. Data analytics and quality and utilization, probably can't say it enough. I probably already bet my credits already on this one, but this is huge. We have to get it right, because downriver is where this really all starts to come together and make sense. But we want to make sure our clinicians have access to clinical decision tools and improved efficiency, improved care coordination. I get this question a lot. I wouldn't be shocked if some of you asked this question. It's like, how independent can we all be as providers, right? Providers kind of want to do things the same way. We used to kid that you could put 10 doctors in a room, and if you could get 6 of them to agree on the same thing, you were probably doing pretty good. And that may not be different. But I think if we actually look at what's the end game, and if we are supposed to be reporting data and outcomes based on standards and metrics that, again, we don't really know yet, but we know there's a lot of health departments that are involved with what's coming. I think we're all going to end up feeling like our providers are doing a lot of the same kind of work. So hopefully it's all based on best practices, that it's evidence-based, and that it's all going to be something we can sell them on to be able to embrace and do this so that we can actually get to where we're going. And I guess enterprise EHRs, I hear this a lot. Recruitment's a big thing for all of us. And if you've got an EMR that the providers are happy or comfortable with, maybe they went to school and got trained on it, can't hurt you. It helps bring these folks in and to retain them. So we need to look at that. And we've got to take a look at where can we reduce service cuts and reductions and keep services local. This is a big thing. So where I'm going with a lot of this is, what are the things that we can control? If we have enough money that we have to make a decision to do an EMR, should this be the way to go and spend less, but to gain a lot more? And everything we're going to talk about today is, what could we do with what we have today so that we can improve our position as it is today, as opposed to relying on what the government's going to do and really save us and will we have more money than we thought we were going to get. So that's kind of the strategy where we're going. And the last line on here was cybersecurity, HIE, predictive analytics, modernization requirements. All of these are embedded in a lot of the language. So how do we get there? So I think the EHR is a big piece of where we start, but that's just a tool. So virtual care is another area that I spent a lot of time looking at, and I've got some data and some resources to share on that. But again, what are we doing with virtual care? There's some opportunities that we need to support bedside nursing. We start talking about ratios. We start talking about burnout. We start talking about retention, and again, compensation still is always a factor there. So how do we keep what we have, make sure everybody's fairly and appropriately compensated? Well, I think we're going to have to use a lot more of the tools, and we may have to rely on some outsourcing. So virtual care works internally within your own organization, but it certainly can be something that could be used outside. In other words, firms are doing this today, providing the service, doing the documentation, and helping you guys collect more of the charges that you're supposed to be getting. So we want to improve that satisfaction. Patient satisfaction goes up because we're finding a lot of patients appreciate the technology. We need to have throughput. We talk about that all the time. Discrete safety events from non-standardized care, reliance on contract nurses, the travel nurse thing. Wow, everyone knows when we had to do that, it was really painful and expensive. So we've got to try to avoid having to get back into a situation like that. And of course, decreasing overtime and premium pay. So how are we using tools to save time and increase satisfaction, performance, and of course, outcomes? So just a quick slide here on some of the areas. Virtual observation, sometimes we call it sitting. Now, this isn't going to work for every hospital. I realize that some hospitals don't really have a need, but some have a larger need. So it's a matter of how do you do this? Possibly you find a vendor that can give you an a la carte service for those that wouldn't really need to sign up for anything all the time, but it's only on occasion that you have that. And if you don't have the staff that can sit 24 hours in 3 8-hour shifts with a patient, this might be kind of a solution that might work out really well for you. Predictive model surveillance. This is big. We need to be able to tell nurses which patients are most likely the ones that they have to spend more time with. But we can't get them into those patients if we've got them burdened with all these other things. All of this loops together, and I find it very fascinating, but it all points to we have to try to bring services to bear. Maternal surveillance, that's a thing. We're not talking about just in the hospital, but what happens when you send the moms home with the babies and there's the postpartum conditions. We want to be able to make sure that some of those patients, which could have been identified through predictive modeling, that we're tracking them when they go home to make sure everything is good. Transformation models, again, that's an opportunity for each hospital to figure out how do we want to make a transformation, what's best for us. But again, we free people up, we provide economic opportunities, and you're good to go. And then there's the telemetry and other components that might be in there as well. So a couple of pieces, like I said, I like to do the numbers. So using some local data that's generated by my system, I think you're seeing some pretty good, decent numbers for the SCP-1 bundle compliance, 40% increase in compliance. I like those kinds of numbers. Reduce the happies. Decreased number of NQI falls. Everybody talks about that. So if we can reduce these, that's obviously good, and it lowers the cost. It's just all the way around. That's a thing. Fall prevention is something that we're talking about, and virtual nursing can help do that very well. 24/7 monitoring, eyes on a screen, and the things that we're finding is if we have one person who is watching 10 patients, the cost should be about 1/10 of that, roughly. But it kind of gives us something better than one-to-one, a person in a room, 24 hours a day, paying them a salary to do that. I think this is where we can actually have an impact. And of course, utilization and nursing admission programs. Some of the things that we're also getting into and seeing out in the market by other places is virtual admit and discharge. So that's all being done by devices that may already be in a lot of the rooms today, others that you can get in affordably. I think every major vendor that's out there, at least from an EMR standpoint, has a solution and a tool to make this thing happen. So I think it puts us in a spot where it's doable, right? I'm suggesting things that I think we have a chance to get to. They're within reach for most of our rural hospitals if you find the right partners and set up the right plan. So a lot of things you can do there. So the transformation models, again, you start talking about the vacancy rate satisfaction. We've got to put solutions together that make it all the way around. It's got to be good for the nurses, got to be good for the patients, good for the organization as a whole, and we've got to be able to do more with less at less cost. Okay, so quick benefits on this one. Then there's only a couple more after that, but I think we're doing okay. So rural health benefits, and again, I did the AI work to see if we could kind of get it tuned to what I thought would be our audience today. So we have to shift care to predictable lower cost and virtual care models. So I think we have to figure out how to do what you do, make sure that we're capturing everything that you've already earned. So we're not leaking, we're capturing more, we're optimizing, we're reducing staff burdens, free nursing up to do the things that they need to do. Again, that goes back to what is our nurse to patient ratios, and are we having them all able to work at the top of their license? You know, I really like that, but we want to get them at capacity, but working in the best ways possible, not doing the things that they shouldn't really have to do. But some quick numbers out here on the savings for a 25-bed hospital, $250K. I know it doesn't sound like a lot, um, but these kind of things start adding up incrementally, and I think they do have some value there. And again, falls dropping, you start looking at, you not just have the problem of the patient staying in a length of stay, but then you got penalties. So we really got to factor in everything that's involved with having a problem that we could fix pretty easily. Virtual admission and discharge saving, 45 to 90 minutes per RN shift. It starts to add up. So I really don't think these numbers are terrible. I think we need to not just dismiss them like you might. Um, Avoid harmful events, reducing length of stay, readmissions. Again, all of these things I know you know about, but when you start looking at what virtual house does, when you start touching all of these bullets, it makes sense. And there is an opportunity to target this. A quick pause. Allie, is there any questions or anything you want me to address?
No questions at this time.
Okay. So revenue cycle, this has been around a long time. Everybody knows it. I won't go into a large amount of detail, but one of the things that we're finding when we do our research and market analysis is it's not that people necessarily want to get rid of their revenue cycle staff. I get it. And that's not a problem. But what the biggest thing we hear is we've got some really high skilled folks that really know the business. They know what they're doing. They can do it with their eyes closed. And they've been here 40 years. So they're going to retire. Or something's going to happen and staff are going to figure out that, hey, I can do the same thing from my couch, but get paid $5 more an hour and work from somebody on the East Coast or whatnot. And that's tough to find the replacements. We're seeing that coding and billing schools, and in my background with medical records, I had to go to a coding school, and they're not turning out as many people anymore. Why? Because the technology within these EHRs are doing a lot of the work for us. With AI being introduced, it's only getting more so, and it's getting faster. And no one ever takes a break or takes a vacation. So I think we're seeing where this technology is coming in. Hence, there's a lot of folks not going into the business to look at it as a career anymore. So what do you do? I think what we're looking at are some opportunities where we've got uh, hybrid situations. What might be the a la carte piece that works best for your organization? But we have organizations, there's a ton of folks doing revenue cycle work, everything from soup to nuts. But we look at the overhead of IT that's involved if you're doing it yourself. We don't want to ignore that. These are things where if we include this into our performance or our returns on investments and don't miss all the things that you're already paying for, you just gotten used to, these might come off that budget and be an offset for you. So again, I'm not advocating that we terminate anybody at all. I don't think you need to. I think there's plenty of work that we might be able to find some very sensible reassignment. As a matter of fact, the more AI comes in, my wife is works for a company that rack auditor kind of thing. So they audit insurance work, not for Indiana. I'll make sure I share that. She does not do Indiana, but for other states and the Department of Defense. And the game and what they've got going on with AI tools is to review all these charts and find out where they're not going to pay. So we already know there's a ton of things working against us every single day. So how do we keep up so that we're fighting the best fight we can and we're not showing up to a gunfight with a knife? And I think that's the things we're talking about here. We can do that from the technology that's coming out of these EMRs to begin with, plus some additional technologies that we might find from a good vendor partner solution that's out there. And we have to figure out each hospital, what's the best fit for your particular environment. And those are the things that my company and what we're doing, and I'm super passionate about, if you can't tell, is how do we find the things that work for you? Because at the end, we really want you to make it through this. We need you to be there doing what you're doing. And you're going to have to do it with a whole bunch of help and a whole lot of partnerships. But again, lost charge capture. I can't tell you how many times in 14 years of working with just the product that I've been working with, let alone the 29 years prior to that. But it's turning out that there is a lot of leaking. A lot of times people don't know where it's at, and it's everywhere. Pharmacy bumps right off the bat, but tons of other areas where you could have did a little better, and it's work you already did. I'm not suggesting that we have to go find ways to generate new revenue. How about if we just capture all the stuff you already earned and deserved? Let's put that into play. These are the things we want to make sure we're targeting. We want to get down to the front end and the back end of our cycle on the revenue side. The mid-cycle is important, but we want to make sure that when we're doing this mid-cycle, that the objective is we're giving good care, we're meeting all of the standards, we're collecting the data that we're going to need. Remember, back to that reporting, that's all going to happen. We want to drive good outcomes, but that also should help us get better reimbursements. And we want to get these things in faster, so lower denials, lower AR days, and we want to make sure that these collections are hitting the mark, you're earning what you've done. And of course, increased days on hand. I hear that a lot. And it doesn't matter where I go, Indiana, Ohio, Michigan. We're seeing the clawback taking effect in certain areas. So days on hand for one organization yesterday, after the clawback got announced, you just lost 13 more days. These are impactful, and I know they may not be as big of a deal for a larger hospital system, but it absolutely makes a huge impact on the rural health. These are the things that we want to try to figure out. How can we help with the things and tools and opportunities that you already have with you? Our revenue cycle service, this is just a slide to kind of share. These are all the things that we should be looking at, and there's a lot. But in particular, eligibility is a big topic that I see that, and prior authorization certifications are there. Old fashioned is picking up the phone, going out to websites, right? Doing that kind of manual research. This stuff's happening instantaneously, folks. If it's not already happening with your EMR and it's available, I would suggest go take a look at it, see what you can do. But these are the things we need to do. We need to take the burden off the front end and burden off the back end, because a lot of that can be done with automated tools and getting it right. But focus somewhere here in the middle. Let's focus on the CDI. Let's talk about case management, utilization, and benchmarking. What kind of guidance can we get? If we don't have the resources, there are folks and organizations out there that do. And they've got the folks that can have proven track records that are going to help you come up with a plan that's going to get to where you need to go. And again, I can't help but say, just from what I've read on the Rural Health Transformation Program information, they're going to ask us to do it anyway. So let's just do what we need to do so that we can cover all the bases, check all the boxes, and maximize our opportunity. A couple of examples here on case studies. These are, I think, maybe larger hospitals. So we have to look at this as a linear approach. You know, the bigger you are, the bigger the outcome. So we have to back a lot of this off. But again, I'm a data person. So when we do these kinds of services, where are we at? Where do we have opportunity? So when you start looking at, keeping those number of AR days down, it can happen. It does happen. The numbers may not be as big in our smaller rural health hospitals, but I had a customer tell me the other day in one of my rather small rural health hospitals that he'll tell you is in the middle of nowhere, but very excited about the fact that he had his greatest, just from using the technology and the landscape of what we were talking about. Didn't change any staff, didn't hire an outsourcing company or any of that, but started seeing significant increases in the double digits when it came to capturing revenue that they weren't getting before for the services that they hadn't changed. In other words, stop the leaking. These kinds of things happen. You've got automated tools now that are letting providers know something's missing. Not telling them how to document, but saying, based on what the rules and the guidelines are that you said, this is something that you probably want to check. And it's up to them to choose to do it or not. But when you follow all these guidances, that's going to get you to those better outcomes that we've been talking about, which generate hopefully better claims, lower denial rates, get the money back in the door faster, and then become part of the reporting that we send out to the state and the Fed as we're following all these participation programs. And a couple more case studies here. I know Allie said this is going to be recorded, so we won't go through this. I'll give you a chance to go back out to the Rural Health Association website and pick this off and take a nicer look at it. But again, one of the things we're talking about is we want to have standardization. You can get there. Hybrid delivery models are all out there. Don't think you have to go all in with a revenue cycle option, but you can. Everybody has to take a look at their models and what are you looking at? What are the staffing personnel? I've got a couple of places that I'm aware of in another state, and most of their staff is really at that point where they're all about to retire. And there's a little worry that the folks that coming in behind them that they've been coaching and training will never have the skill and the experience and be able to do that. So what they're worried about is we're going to have bodies doing this work, but we probably expect that we're going to start seeing drops. And that's not the answer we want to have, right? We're sitting here talking today about how do we do more with what we've got. So we have to take a look at a lot of different options. Physician engagement is still always going to be important. I think we need to be able to do that with some elbow to elbow support, strong education, make sure they feel that what we're doing is that people aren't telling them what to do, but how can we help make their day better? And you're seeing a lot of that with the introduction of AI tools that are coming in even down to the AI documentation. A doctor loves it when they can see 2 or 3 more patients, whether they actually translate that into seeing 2 or 3 more patients, or they're getting out of the office with better documentation, getting home a little earlier and getting that family time. We're still getting a win there with satisfaction and reducing the burnout. So there are a lot of different ways to look at all of the things that we're talking about here. But we do want to recruit physicians, and we want to keep them when we get them, and we want to make sure that we're using everyone to top of license and at capacity as best we can. All right, some of the benefits that I again collected. Lots of notes. There's a lot of ways to address RCM. We talked a little bit about that. So a lot of qualifiers in here. No one solution is probably going to be the best for everyone, but think about a la carte options. There's a lot out there, and you might find something that works out super well with you. But we want to see revenue increases that we're seeing that are out there. Again, 5 to 6%. Doesn't sound like a lot, but definitely starts to add up when you look at the rest of the bullets. Revenue cycle operating expenses through outsourcing getting reduced. Again, some of that's technology, some of that's staffing, some of that's just being more efficient and getting more done with less people. But 20 to 40% increase is pretty impressive there. Everyone wants to see the AR days dropping. Those numbers are there. You can find all this information just as easily as I did. So not too worried about it. It might even be better for you depending on your scenario, or worse if you're super good at it right now. Collections uplift 5% through mid-cycle. Again, you've already done the work. We need to get the money in the door as quickly as possible. And these are the things that technology and good advice, good partnerships can help us get to. The case studies that I presented here a little earlier, based on a vendor and large hospital collaborative efforts. It wasn't one thing. We can't do it on our own. The software can't do it on its own. It's going to take a combination, and we're going to have to figure out how we create these affiliations. And again, not from a scary word standpoint, but how do we work with each other, benefit, lean on each other, take advantage of where we have strengths, and let somebody else help us with our weaknesses together and come up with a nice hybrid model that works. Allie, I'll give it a quick pause. And am I doing okay on time?
We've got about 20 minutes left. So again, if anybody has questions as David goes along, you can put those in the chat or the Q&A, or you can hold them till the Q&A at the end, and you can raise your hand and ask your question verbally.
Yeah, thanks, Allie. Appreciate that. We're looking pretty good. Challenges that were noted, and for rural health pharmacies, right? Rural communities with limited pharmacy access. Definitely a tough one. Medication management always has been complicated, but it's only going to get harder as we have to start reporting. So I think we're going to need a little help there. Medicaid and ACA coverage shrinking. 340B, right? Looks good, but it seems like that's a moving target. I just read another article today that looks like there's some more things we got to be taking a look at. And it's different state to state, but it's always tough. So how are we going to do this? 340B, audit readiness, can't get around it. We've got to make sure that we've got everything that's up to snuff. Reporting is accurate, that it can be validated, anything that we're sending in. But we need to make sure we've got accurate eligibility determinations. Contract pharmacy optimization is another one. Bigger term, it's a lot broader, but pretty interesting when you start digging under the hood on that. Probably something that I'd love to have some conversations with folks on that if that ever pops up. But we need to get lower chronic disease management burdens that are on hospitals. As we're trying to get into standards, as all of this data needs to be reported up through each state and up through the Fed, we've got to try to find solutions that are workable, that are manageable, affordable for our rural health hospitals. I don't think any of us are going to get that lucky that all the smart people show up at our place and this can get figured out on its own. Probably not going to happen, even at a big place like Parkview. So we've got to figure out how to work together. Hazardous medication management and the compliance there, along with the safety from our own staff being able to administer these things. That's a big area of concern that we're seeing a lot in marketing, and exposure risk, of course, from our caregivers that are providing these things and handling. So that gets down into outside the patient, but now into materials. Outpatient retail pharmacy setup, that seems to be a topic that we're seeing a lot more of that. Certainly a lot of interest, but how to do it well, how to make sure that it's the investment is set up properly and it's moving in the right direction. So how would you get there? A few ideas that I've pulled together that I was seeding out on the market. is these pieces here. 340B is the hottest topic that's out there, but there is a lot of specialty light pharmacy management that's out there. It's getting harder to find a pharmacist in some of these very rural areas. It takes a long time in some cases, or it's super expensive to get them to draw in. So, how can some of these other opportunities for outsourcing come into play? So, it could be advisory, could be full staffing. All these things are out there, and I wanted to share that you've got a lot of options you may not have been aware of. But at the end, no matter what we do, we want to hit these pieces, right? These are the things that seem to be the most important and creating the most impact. But 340B, strategic, operational, and audit ready compliance, it's big. And again, a moving target, as we talked about on the last slide. But health plan pharmacy management, gosh, I can't even try to keep track or say that I know much about health plans and how they work, but I think they're complicated and a moving target. And every plan has different carriers behind it and different strategies and structures. So it changes. And as a patient, I never know. And it's complicated. So it's got to be tough on our pharmacists and the hospitals that are providing these services. And medication assistant program management. It's old news. I've been around this business a long time, but we used to always talk about patient compliance with taking the meds. Do they take them on time? Are they cutting the medications in half to save money? Well, if we do all this, we know what happens. Now we're increasing the patient's risk. They may end up in the ED. They may end up with, gosh, the ED doesn't even know exactly what's wrong with the patient because it says they're taking these meds. They didn't tell you they're only taking half of them. So it really takes a lot more analysis, decision making, and maybe some more risk, which we don't want on our providers that are in these hospitals trying to do these in the emergency room, because risk adds up to more risk and more cost. So what we need to do is, how do we get to these patients? And again, they have to stay rural. This is the best way it's going to work. Your rural patients are going to trust you, not when they have to drive an hour and a half to somebody else that they don't know with a different brand on the wall. We've got to help provide some solutions. And I think that pharmacy management is something that's out there. It's growing. And I definitely think it's something we should all be considering, because we really want to find packaged solutions that are affordable, that can work all the way down through the continuum of care. So let's see here. Protect revenue streams, especially with 340B, would be obviously a goal when we start looking at what we can do with rural health pharmacy management help. Moving target 340B. Gosh, I wish things would just stabilize, but it just doesn't work the way it's going to be. So whoever is in charge is going to have to stay and be able to pivot and dynamically make adjustment where they need to. We always need to keep these services local. We need to make sure that patients aren't driving too far to go get services or to pick up meds. But I have seen a couple of pharmacy shops in really small towns that I drive through to get to certain places, and it's just not there anymore. And they're not big enough to have a CVS. So it was a family business that probably moved out. And that's disappointing, because if you're not getting it from the hospital, then you're going to have to take a drive. So we want to keep these hospitals available, and they need to have all the tools they can to keep providing that. Safety net and community health screening, immunizations, prevention, wellness services. That's usually driven by the hospitals. These are programs that if you have more money and have the right resources, you continue doing these things out in your communities. These are all super important. Continuity of chronic medications and reducing non-adherence and preventable admissions. We talked about that a minute ago, but it happens a lot. Partnerships, contract partnerships with 340B. That's a big thing that I think can't do it alone. I think we can do it together, though, and let's figure out ways to make that happen. But we also want to increase the capacity of potential new service offerings. You saw on the very first slides, 25% of the hospitals are reducing services one way or another. And some of these are in the tougher ones, the behavioral health, the OBGs, and some of these other critical really have to have it in the community type services. And that's a problem. So where can we save money? Where can we make more money? How can we optimize performance so that we have more resource and capacity to do the work, so we can keep these things going? Otherwise, it's going to be bad. And it's going to be bad all the way around. And we want to lower those ED visits and readmissions. And we're talking about the stuff that really shouldn't show up in the ED, right? Not just the little things that really could have been and should have been prevented. We need to make sure that we've got the bed management in the ED flowing properly, that we're not transferring patients if we don't have to. We need to keep patients moving into the beds inside the inpatient setting at the local hospital as much as possible. And we can if we've got the right controls and the right resources, and we're doing the right things out in the community. So here we're just about done here. Just some suggestions and goals and objectives. Find a trusted partner, whether it's with a large health system or your vendors that will help lower costs. One of the things I've been doing for at least through the last 14, 15 years was knowing that the EMR was never going to be the only thing. How do we have all these peripheral and ancillary products that are coming in that we need to have continuity, which means I'm going to be suggesting to customers, my other hospitals, that, hey, you should look at this one, look at this vendor for that. And to do that, I just asked them, look, we might be able to give you more volume. You guys need to partner with all of us to try to help make this more affordable for our rural health hospitals. This has to happen. If they go out of business, you've lost an opportunity entirely. So you have to help think the vendor through what you're asking. But I do. I spend a lot of time working with these folks. You can do the same thing. Expect them. Talk to the hospital next door. See if maybe there's something that, hey, if the two of you do it, doesn't have to be anything formal. I'm finding that the vendors are a lot more accommodating and are listening to reason, and we're getting some breakthroughs. Not everywhere. Some of the products you can imagine will never lower their price, but there are a lot that will actually help us. But we want to try to look at where can we eliminate redundant specialty services? Where does it make sense? Turnkey virtual care infrastructure, I think, again, is a big one, from the remote diagnostics and monitoring of the patients, saving a lot of time. Population health insights using predictive modeling. That's going to be big. I am so impressed with what we're seeing with that. Keep in mind, though, predictive modeling, definitely demographic based. It's different by each region, right? Because you're grabbing a mix of the patients and all the data about those patients in your area. In other words, what we're doing in Indiana is probably not going to match what's going on in West Virginia, right? Different environment. They got the mountains, they got the mining, there's all these other things. These all don't mean the same thing across the board. And it will be absolutely wrong if we assume that it will be, and you'll get bad data and then you'll end up doing all the wrong things. So you want to get this right. But I do believe in what we're doing with predictive modeling, and I think you're going to be very excited if you get a chance to do it. For those of you that already are, love to hear what your feedback is if you're finding good results. And all the popular stuff like sepsis and things like that are out there up front. But I'm seeing some cardiac predictive models, which ones in intensive care, which patients probably need the most attention. Even if you're at capacity, there are some that need less than more, and we want to focus on the ones that need the most so we can make sure that they get the best progress and things don't step up. Economies of scale to meet rural health transformation strategic goals, right? That's, again, we can't do it alone. How do we demonstrate economies of scale? They're going to want to see that we're doing something. So let's be able to put ourselves in a position to make that happen. And of course, our grant competitiveness with strong ROI outcomes and analysis and reporting. I haven't seen anything that shows exactly. We all probably looking at the same things on kind of what the targets are, but that's not been super well defined yet. Hope it is before too long. But as we apply for the grants, we obviously all want to try to make as much as we can and gain as much as we can, but we still have that 200 million that's going to be shared. And I know there's questions too on whether or not that entire 200 million is going to make it down to every hospital. I know there's a lot of things in play. So my perspective is we'll take what we can get. Let's put everybody in the best position to get the most, but let's also make sure that when we've got things in play that we can actually keep that flow coming for the next 5 years and keep battling the headwinds that are always going to be there and have the best opportunity to not just survive, but thrive. And that wraps up my presentation. I know I talked fast. I hope it wasn't too fast, but Allie, I'll turn it back to you.
We don't have any questions that have come in, but we will obviously go ahead and, well, hold on, maybe one just did come in. Okay, yes, right now. I lead a company that works with early adopters of health tech, so I'm very aligned with your point about finding the right partners. One resource they would like to share is CMS's Early Adopters Program and the Health Tech Ecosystem. It highlights organizations already operationalizing interoperability and surviving the problems that you've talked about today. So that's something that was shared. CMS's Early Adopter Program within the health tech ecosystem.
Excellent. Thank you. Was there another question or two?
No other questions right now, but as I say, we'll leave it open for just a moment. If you would like to use the raise hand function, we can unmute your line. You can ask questions verbally. David, thank you so much for your presentation. Just a ton of information in there. I'm glad we recorded because I can imagine there might be some follow-up questions.
Thank you for the opportunity.
Absolutely. Well, David, thank you once again. Everybody else, thank you for joining us. Have a great day, and we will have this up on our web or on our YouTube channel in the next week and a half. Thank you all.
Thanks, everyone.